great applause to you.
And with that, we continue with our next presentation to describe the long pathway from managing the acute pain to chronic pain management. And with that, we have the pleasure of inviting Dmytro Dmytriiev, Professor, Medical Director of Vinnytsia Oblast Regional Clinic, anesthesiologist of the Center for Reconstructive Surgery, and the Executive Director of the Genesis Pain Treatment Center. Thank you, my dear colleagues. I have to admit that the previous speaker, Volodymyr, was kind enough to describe most of what I was intending to include into my presentation, thus making my job easy. So let me focus on some patient cases who were admitted to our pain management center. And here I again have to emphasize that unfortunately we don't have any unified protocol, no unified guidelines. And when speaking about the pain as an issue, particularly in case of amputees, this is a problem that persists, because looking at numbers, between 20 to 50,000 Ukrainians, they have lost one or more limbs, and they are suffering from phantom pains as one of the adverse effects following the amputation. Especially if we are talking about chronic pains, stump pains, phantom pains, pain following the concussion or following the injury of nervous tissue by the fragments. And looking at the statistics, unfortunately, the number of such patients is ever growing, no matter what source of statistics you refer to. So we have to discuss not only the amputations, but also the mine and blast injuries, which are quite common among our patients. So we have to provide adequate care to acute pain, but also prevent development of the chronic pain. So again, Volodymyr has covered most of that, and now I will focus on the patient cases. I'm afraid I'm repeating myself, so let's pay attention to these snapshots, remembering that we have quite a high number of patients coming to our reconstruction surgery. That also would be involving fragmentation, that would be involving different mine blast injury. You've seen similar pictures yesterday as well, so we are not unique in this. That's what we are managing, and this as well. Fracture of the ribs associated with the pain syndrome. So looking at this particular patient case, it was published, and here you can see number of fractured ribs with inadequate pain management. He was admitted with chronic pain because it was more than a year after the original injuries, so it was we had multiple associated difficulties on top of that. Unfortunately, I have to admit, sometimes we have to deal with children. This, for example, is a gunshot in a case of a 16-year-old Ukrainian boy who was shot into back with a handgun, and fortunately he recovered without any neurological impairment, but the bullet positioning was very dangerous, and one of the major problems we faced was the hazard of developing the chronic pain syndrome. So this is a sad fact of the war we have to deal with. But trying to summarize, we have three main problems: treatment of acute pain, prevention of chronic pain, and adequate treatment of chronic pain, including phantom pains, but not limiting to that only. So just like Volodymyr emphasized, we have to develop uniform and comprehensive guidelines, set of guidelines, to make sure we are all on the same page, but even more so importantly, on the same wavelength with our treatment strategy. Analyzing some of the data, please pay attention to the numbers about the prevalence of use of analgesics in the battlefield. And as you can see, This is far away from an adequate situation that we would like to observe, and thus we have to deal with the aftermaths. At this point in time, I'd like to emphasize that in most cases, we have patients admitted with the catheters, I mean the peripheral catheters, which is a good sign, because my role will be limited to visual surveillance only. If everything is okay, we continue managing the patient in line with the earliest tactics, making sure that we do our job right. And that's where and why the appropriate pain assessment prior to further management is important. Investigating the case, interviewing the patient appropriately, believing what the patient tells us in case of pain report, because sometimes we are neglecting the importance of having such interviews. Then, speaking of the options to choose about the appropriate management, that is an important prior to delivering the respective intervention in a timely manner, and also evaluating the efficacy of the intervention, and thus reassessing when and if required. And referring back to Volodymyr's case, that's exactly what and how should be done in our routine practice. Speaking of fundamental principles, first and foremost, accept the self-reported information from the patient. We do understand that healthcare providers are very busy, on which also results to some burnout, and thus preventing us from delivering adequate care. But it's also important to use the same scale to get the same assessment results. Documenting, reporting, and tracking results over time, just like Theophania Clinic is doing. Once you get your anesthesiologist on board and the case is referred further, all of the facts should be specified in the patient case documentation, making sure that we have consistency in our treatment regimen as well as pain management tactics, instead of playing around with different substances, and also addressing some misconceptions, because sometimes, remembering how strong and bold our Ukrainian servicemen are, you ask them direct question, are you in pain? And the bold answer is no, even if he is at 5 out of 10. So definitely helping the patient to do self-assessment, to actually discover how strong is the pain, is important. For example, in our clinic, we are also practicing some collateral factors, environmental factors, which might be strengthening the pain. For example, the news outbreaks. TV news are prohibited to be broadcasted in any kind of clinical setting, and that also helps, surprisingly enough. Then pre-operative measures to assess and control the pain. So again, we have to investigate the patient history, the opiates. This was mentioned before, and we are acknowledging that. Also, the nabuphine is commonly used by the servicemen. We have to accept that as a fact, because with that in the background, you can't expect that other painkilling medications will work effectively. So managing the pain respectively, and then the regional anesthetics and the blocks, that would be the most adequate technique to manage the pain, particularly acute pain. And then preemptive pain control, that is something to be remembered. And don't forget about the role of the surgeon in that process. And then, of course, using different ways of administration of the pain-killing substances, which will be resulting in the diminishing of the chronic effect.
So factors, it's not only the pain syndrome, and it can be difficulty breathing, difficulty swallowing, also the temperature, high temperature. So all the factors that we have to consider in order to decrease pain, because they can trigger or provoke or increase the intensity of pain. And this is multi-center perspective study, the pre-hospital analgesia in American theater, combat theater in Afghanistan. Ketamine is forgotten very often, can be used in infusions, continuous infusions of ketamine, good method to treat acute pain, chronic pain, to decrease hyperalgesia, also is good thing, good drug that we can use. Effective treatment of acute pain requires multimodal approach, synergy action of analgesics, decrease dose of opioids, not to exclude the use, but still has to be monitored, control of acute pain and regional anesthesia, alternative analgesics as well. So what are the medications that can be used? We can see that here we have them all, and of course in our clinic we use regional anesthesia methods more and analgesia more. So probably we are on the same page with Fania Clinic here. Different types and forms, humanitarian aid is there. Also, we use that, fentanyl, for example, morphine, in a syrup formulation that can be used, and casualties respond to it more adequately and accept it better. Don't forget about ketamine and its use. Here you can see that. Very effective method to treat acute pain, clonidine. DMN can be used also to decrease chronic pain syndrome. Non-steroid anti-inflammatory drugs can be used, and also gabapentin, pregabalin actually proved their efficacy to treat acute pain and to prevent chronic pain. That can be used as pre-medication or preventively. Gabapentin, for example, to decrease chronic or chronization of pain in our patients. According to regional anesthesia, Volodymyr actually has mentioned basically everything. It's just to show more slides. You can do the blocks or should do the short blocks that can be easily performed. So for the patient not to wait for a long time. If we have time, we can do more complicated blocks to treat acute pain. The thoracic paravertebral block is a difficult block to perform. So to treat pain syndrome, we should use this one. Key things. ESP block can be easily used. One problem, analgesia is not as efficient as thoracic epidural anesthesia. But we have other methods, but that's a separate topic. Our patients, we can see everything here, regional anesthesia. Review shows that it is efficient to treat acute pain. Very simple methods, single shot, peripheral catheter, depending on timing and necessity. So inefficient analgesia factors. So there are some of them that we have to consider, that maybe in different injuries we will have different protocols for efficient pain relief. So in which injuries, what kind of pain relief is to be used? So we have such patients, for example, a patient who had this problem, so fasciileal block that was accessory, quite efficient, decreased the pain syndrome in our patient. Such methods can be used as well. Fascioiliacal block or femoral block can be used to do the pain relief. So for all patients who had trauma or surgery have to have efficient analgesia. Sometimes patients can refuse, well, and you have to consider that and respect that such cases also happen. Surgical procedures should not be vetoed. Like all methods and protocols should be used, so we will be treating them the way it should be appropriate. The anesthesiologist has the right to offer the whole range of methods, and for the patient is to choose. But it's better to use as a multidisciplinary team to offer different options by different specialists, psychologists, rehabilitation specialists, PTs, OTs, whatever, in order to adequately treat acute pain. Regional anesthesia has place on all the stages. Thank you for your attention. Everything's going to be Ukraine. Dmytro Dmytriiev. Yeah, timing is wonderful. Yes, thank you for keeping to the agenda timing. Maybe if we have questions very briefly, we will try to do it as brief as possible because of our timing. Thank you, Dmytro, for the wonderful lecture. My question, please tell us, unfortunately, so the question is to you as to a pediatric anesthesiologist. Unfortunately, children also have some mind blast injuries, trauma. So are there any age-specific peculiarities of features of the risk of chronization of pain? No peculiarities. Children have that. So maybe the percentage of chronization of pain is not as high as in adults because there are different factors that can influence that, and there is a plasticity in a pediatric, in a child is better than in adults. And there are some problems of off-label use of some of the drugs. So the labels do not have that for children, but so that's the only problem. But when we have protocols, if we have protocols, it will help us a lot. Thank you. Thank you, Dmytro Dmytriev. A round of applause to you. Thank you for being with us, and thank you for joining this.